Welcome, everybody. It's a pleasure to be here. That's me at the bottom, and today I'm going to talk about fatty liver disease from tackies to transplant. Yes, from tackies to transplant. Tackies are my enemy. Laura calls this the tacky talk because you'll see why in a second. I'm one of the liver doctors, and I actually do the transplant clinic as well. So I also see GI kids. So if you have sent kids to see the GI department at Seattle Children's, you'll see my name. I do everything and anything. I have nothing to disclose. Today we're going to learn about a lot of things. Fatty liver, differences between NAFLD and NASH, how to treat it, why does it happen, and hopefully you leave here hopeful that this is something that you can actually treat. We already did this, so we're going to start. So what's fatty liver? So when we say NAFLD, or non-alcoholic fatty liver disease, we really refer to a spectrum of liver disease that starts with fat accumulating in your liver. Okay, we don't know why specifically, and we'll talk about pathogenesis in a little bit, but it's a spectrum of disease. Not every fatty liver is the same. In general, and I don't like this, but in general, it's the diagnosis of exclusion. Means that you do laboratory workup, you do imaging, you rule out other things, and then you end up with a fatty liver diagnosis. Especially alcohol is something that you need to rule out in adults, but we also know that that can be a possibility in children. But in general, the kids that I see with fatty liver, alcohol is not, thank God, a component of their disease. It really truly is a hepatic component of metabolic syndrome. Like, these are kids that are obese, they have dyslipidemia, they have insulin resistance, and then their liver disease is fatty liver, same as they can have hypertension and others. Now, risk factors for having fatty liver disease include, obviously, insulin-resistant triglycerides and obesity. But not every patient that has fatty liver is obese, okay? Not every fatty liver patient is obese. Actually, for example, Asians, we see a lot of skinny fatty liver. They have fatty infiltration of the liver, but they're skinny. And that's a big population that we miss because you look at the kid and you're never thinking that they're going to have elevated liver enzymes because they don't come with the other risk factors. But they actually, by the time we see them, their liver enzymes are high. Usually it's like abdominal pain, and then somebody checks their liver enzymes, and they can have fatty liver and be skinny. We don't know why. But again, not every patient that has fatty liver is obese. Big component, but not all. So unfortunately, obesity, it's spreading like a wildfire. I trained in Texas, and about 50 to 20% of children are obese. Here in Washington, it's a little bit smaller. I'm from Puerto Rico. We're not on the poll, but I bet like about 20 to 30% because we're Hispanic. They did a study way back when, and they distributed, they were trying to stratify like which kids were a little bit more obese than others. And they identified that males 6 to 11 are going to be your highest risk factors. They are actually like going up, 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 and actually more discrepant than the other age groups. So males 6 to 11. Stratifying by race and ethnicity, your minorities, Black children, Hispanics, are going to be even higher risk factors for obesity. Not necessarily for fatty liver, but again, males 6 to 11, your minorities. And this is going with the epidemic of obesity. Now, if you track BMI-C scores of children throughout decades, actually, even though we know that the kids are getting more obese, when you compare that to the amount of fatty liver that we're diagnosing, it's going way higher. So more and more fatty liver than actually the BMI raise. That leaves us with about 10 million children with fatty liver in the US. And that actually costs now fatty liver to be the #1 cause of chronic liver disease. So it's not biliary atresia, it's not the ones that we actually worry about. It's not your cholestatic, your jaundice babies, but fatty liver is the #1 cause of chronic liver disease in the US. And actually that extrapolates to Europe as well. So it's not something that we're only seeing here. The prevalence in 2 to 4 years is less than 1%, but I think these are like fake news. I think it's higher, but we're not screening them, so we really don't know. Once we start screening them, which is according to the AAP guidelines a little bit later, but 15 to 19, we estimate about 17%. Now, if you grab obese children that have elevated ALT, about almost 40% of them are going to have fatty liver. So obesity, again, we know that that is a risk factor, but not all children that have fatty liver are obese. 11 to 22-year-old, if you're Hispanic, you have a fourfold increase of higher risk of having fatty liver. We know, we see that, little Hispanic kids. 10% in Asians, 9 in white, and about 1% in black children. And why is that? So they did a study a couple of years ago in Dallas, and they found genetic prevalence. African Americans have a protective effect of fatty liver. They have more hypertension, for example, but less fatty liver. And Hispanics, we have more fatty liver and other comorbidities. And it's, again, genetic predisposition. How does fatty liver happen? So there's a defect in your metabolism of fat in your liver. So diets that are high in carbs and sugar cause more accumulation of fat in your liver. Carbs. What do we eat? What do I eat? Rice. Every day, all day. That's the only thing I know how to cook. Rice, bread, tortillas, takis, and others. And obviously your sugar, Gatorade, ice cream, all the delicious things. Carbs, what can I say? Now, the problem is that fat in your liver is not necessarily bad. So there's something we call bland steatosis. That is just fat in your liver, but it doesn't progress to inflammation. You need inflammation in your liver with that fat to actually cause problems. And that's what we call the two-hit hypothesis. So you start with your diet, your metabolic syndrome. You accumulate fat in your liver. But then you need probably a second hit to then shift that from your bland kind of like fatty liver into what actually NASH is. So when you're talking about steatohepatitis, you have biopsy-proven inflammation. And once you have NASH, the odds of you evolving into cirrhosis are really high. The problem is that just with laboratory workup, you cannot differentiate between the two. You can have really high elevated liver enzymes and just have bland steatosis, and you can have relatively normal liver enzymes that have NASH, which is a problem because still to this day, we have not been able to identify a non-invasive marker to distinguish between the two. And like I said at the beginning, it's a spectrum of disease. You start with a normal liver, you add fat, you add inflammation. Once you're in NASH, pretty much you're gonna go all the way down to cirrhosis, which is a problem, and it's really scary for us hepatologists. We don't know what tilts that balance between the fatty liver, the bland steatosis, to the NASH. But once you have NASH, again, your liver-related morbidity and mortality goes up. Scary thing for us, in a study of children with fatty liver, a bunch of the kids actually showed fibrosis on initial liver biopsy. So you can have fibrosis again, scarred down liver with any type of ALT or AST. Now, they did a study and they were like, oh, what happens to these kids? Again, natural history. 28 months later, 8 had no change in fibrosis, 7 had worse in fibrosis, and then 3 kids had improving fibrosis. And they were the ones that lost weight. The three ones that lost weight, they actually had reversal of fibrosis. So it doesn't matter if you have scarred down tissue. On diagnosis, it can be reversible if you lose weight. Unfortunately, there's also reports of rapid progression to cirrhosis, and that's why my talk is called From Takis to Transplant, because kids that have fatty liver have been transplanted because of cirrhosis and kind of other problems. So this is not something that you think it's like not gonna happen. This can happen, and this is like what we worry about and why I want you guys to screen for fatty liver. Oops. Now, when we talk about what happens to these kids when they turn 18, they're gonna keep progressing in their disease. And actually, fatty liver is gonna become, some people say by 2020, others by 2030, the most common cause for actually needing a liver transplant if you're an adult. That doesn't mean that you're gonna get transplanted. It just means that it's gonna become the most common cause. And why don't they get transplanted? So unfortunately, a MELD score is the score that you get on how sick you are related to liver disease when you need a liver transplant. But these kids are sick, or adults I guess, but not from liver. They're sick from diabetes, hypertension, kidney disease, and all the other comorbidities. So when a surgeon sees them, they're like, oh, you need to normalize your BMI before I list you, because if not, you're never gonna get extubated, you're never gonna leave the hospital. And these are patients that have never had a normal BMI. And now you're asking them to normalize their BMI. They don't know how to do that. So they get listed for transplant, but they never get transplanted and they die. So this is serious, very, very serious, and this is why we need to battle it now. These are just causes of transplantation in the US in adults, and hepatitis C now has a cure. So for us hepatologists, we're very excited. So hepatitis C as a cause for liver transplant has come down, and NASH is going up, 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 up. Now, again, I'm a transplant doctor, so why do also I worry? The problem with fatty liver is that we have a lot of children that may become donors for some of our other cholestatic diseases, and fatty livers are bad donors. They don't handle reperfusion. They don't handle that stress of being transported. So actually, we have kids that have been transplanted, and then they develop liver failure during the transplant process, and we think it's because the donor, even though we see a young kid and we're like, oh my God, perfect donor, if they have underlying fatty liver, it's a bad donor, which is a problem for us too. And that means that you're gonna have more patients needing liver transplants, you're gonna have less healthy livers that become donors, so it's gonna affect the demand and the supply of organs. So this is scary for me, and hopefully for you guys too. So we have to love our livers, and I tell you guys, it's scary, but we just need to start with the beginning. We have to identify those kids that have fatty liver. How do we do that? Back in 2007, the AAP was like, we see you, obese children of the world, we know you're there, we know your risk factors. Let's try to identify who we can kind of like prevent from having further complications. And they were like, okay, if you have a BMI over 95 or between 85 and 94 with risk factors, and let's be honest, almost everybody has a risk factor, you need to check ALT and AST. Now, normal ALT and AST in children, normal is about 20. 2 times the upper limit of normal is when we start to worry. So that means that ALT above 50 for boys, because it's 25 normal, and above 44 for girls is abnormal. It's twice the upper limit. And I see a lot of times that pediatricians, like you guys are like, oh, it's just 60 or it's just 70. It's not that high. What are they gonna do? Worry about that number. I see a lot of families that they have no idea that their kids had elevated liver enzymes because nobody was like worried about that number because it's not triple digit. Tell them, screen them, and if you don't know how to address it, I'll be happy to see your kids. You guys don't have time to kind of go over the specifics, and it's very important that we screen for other things, and I'll go into why in a second. So again, just to keep it simple, if it's above 50 twice, send them to us. The problem with liver numbers is, like I said, you can have NASH, you can have NAFLD, you can have cirrhosis, and those liver numbers are going to be normal. So even though it's a non-invasive marker and it's the only tool that we have, it's really not perfect. Labs do not rule out fatty liver. Not every obese patient with elevated liver enzymes has fatty liver. You can have a bunch of other things. You can have hepatitis A, B, C, Wilson's, autoimmune hepatitis, alpha-1, hemochromatosis, drug-induced alcohol, you name it. I put an asterisk in autoimmune hepatitis because we see a lot of positive ANAs and positive anti-smooth muscle antibodies in our obese kids, and we think that fatty liver is itself like a pro-inflammatory disease. We see a lot of elevated CRPs, for example. It doesn't mean that they have autoimmune hepatitis. I actually see like low positive titers in the fatty livers, but I use this to then biopsy the kids sooner than later. So we do screen our kids for other diseases, even if they're Hispanic, obese, with family history. So what I tell you guys, again, you see an elevated ALT above 50. You check it once, you check it twice. It's an obese kid. You're still struggling. You recommend lifestyle modifications. You cannot get that ALT to come down. Send them to us. We'll make sure that we're not missing anything. Or if we diagnose with fatty liver, then we'll help them. What about imaging in terms of diagnosis? So there's a bunch of modalities that can identify fat in your liver, and I'll talk a little bit about all of them so that you guys have a good background. So ultrasound is really good at identifying fat if you have a lot of it. So if you have over 30% fatty infiltration, you're gonna see it. Your sensitivity is about 80%. But if you have less than 20, it's really not that good. It's like flipping a coin. That doesn't mean that the fat is not there, you're just not gonna be able to see it. And obviously, the bigger the patient, the less sensitive it is because of problems with the probe. And in general, we do not recommend an ultrasound to screen for fatty liver. And I'll tell you guys why in a second. Imaging, CT, and MR, very, very specific and sensitive for fat. Now, the problem is that you can have fatty infiltration with other diseases. So Hep C and Wilson's are the two big mimickers that we see. They cause fatty infiltration of your liver and liver enzymes, but it's going to be the same thing that just bland steatosis can cause too. And this is why we screen our kids for different diseases. So again, we don't use ultrasound necessarily to screen for fatty liver because if I see fat, it might not tell me where it's coming from. So I hardly ever do a random ultrasound for fatty liver. Transient elastography, have you guys heard about transient elastography? So they developed, this is used in adults a lot. They grab the ultrasound probe and now they can check for stiffness of the liver, and the stiffer the liver is, the faster the wave goes. It's like a Doppler kind of looking thing. And the faster that the wave goes, the stiffer or the more cirrhotic the liver is. So then you're kind of like using it in adults to establish if they're more fibrotic again. But the problem is that in kids, we don't have good reference values. So at Seattle Children's, you can ask an ultrasound with elastography, and they'll give you a number. But be careful because I don't know how to interpret that number. So I don't order elastography yet. What we have been doing is for some kids, if you got an elastography measurement, you can follow that serially and see if it gets like worse over time. But there's a lot of variability if you're fasting, if you just ate. So we still haven't been using it clinically. We're still using it in the research area. But I want to mention it because you can get elastography measurement depending on who your ultrasound radiologist or whatever is. And then liver biopsy. So really, liver biopsy is the only way that we can for certain diagnose fatty liver. And most importantly, is the only way that I can differentiate if you have fatty liver like that bland steatosis or NASH, or if you have fibrosis or not. So by far the best standard that we have. Now, do I biopsy all the kids that have fatty liver? Absolutely not. Like I would be lying to you. Now, but if I see you and your pediatrician has been struggling with you for 5 years, you've had elevated liver enzymes for years, I'm going to biopsy at the beginning. Probably I'm going to give you a couple of chances before I actually biopsy. One of the things that I do get an ultrasound if I see splenomegaly, like a large spleen, that goes a little bit more with portal hypertension, I'm going to biopsy you. If I see also low platelets on a CBC, I'm going to biopsy you because that's going to be a little bit more sensitive to, as a marker of portal hypertension, again, splenomegaly and thrombocytopenia. So those are kids that I'm going to biopsy on the get-go. Or if there's something that just doesn't add up. My Asian skinny kids, I tend to biopsy them more because they come with, again, higher liver enzymes. And I'm like, oh, are you going to be one of those skinny fatty livers or are you going to be something else? So at the end of the day, one of my attendings used to say this, if you have an issue, you need some tissue. So fatty liver diagnosis is still done by liver biopsy. Now, obviously, there's some pros and cons on how you determine that you're going to diagnose them. Obviously, liver biopsy is going to be my gold standard, but it's invasive. It has risk. We actually think that it's a very safe procedure. I do them myself with these hands. But to date, thank God, I haven't seen a complication. I know it's going to happen, but again, we think that it's a very safe procedure. Laboratory workup really doesn't tell you anything. Again, you can even have positive ANAs, positive markers of autoimmunity, and they're not going to have autoimmune hepatitis necessarily. And imaging tells me nothing. We're going to see fat, but it can be from Hep C and Wilson. So at the end of the day, probably it's going to be a combination of those. So how do we manage fatty liver? NASP again, which is our North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, came out with this in 2007. And I get sad because it's like so vague. It's like, oh, avoid sugar, increase activity, no medications work, like pray a little bit, everything is gonna be fine. And then think about bariatric surgery. So it's very vague and it's like, this is what you all know. Like this is what everybody knows. This is what I'm supposed to be doing with myself. And I think fatty liver, unfortunately, you need to individualize what works for each family. But at the end of the day, you need to get them to lose weight. That is the thing that's going to reverse that fibrosis, that inflammation. However, which way you can, they need to lose weight. And I'm going to go over kind of like each specific category, like a little bit of nutrition. a little bit of medications, and a little bit of bariatric surgery. So, what do our kids eat? And this is where the tacky talk starts. You guys know Takis, no? Yeah. You'll be surprised when I give this talk in Seattle. People are like, no, what are Takis? I'm like, ¿qué? You're part of the problem if you don't know what Takis are. This is what's keeping me in business. My whole department actually lives off Takis because they come with abdominal pain, bloody stools. We scope them, and I'm like, are you eating Takis? And they're like, yes, we love them. I'm like, see? And some sassy kids are like, no, we eat Doritos Dynamite. I'm like, they're the same. They're terrible for you. But just focusing on Takis. This is like the devil in a bag. People ask me, have you eaten Takis? And I'm like, no, because I think they're genetically engineered to like make me as a Hispanic like them. And I feel like if I eat one, I'm just gonna not gonna be able to stop. But this is like sugar and carbs. They fry them like 5 times and they add like spices and Takis fuego. I'm like, yeah, that's fuego in your stomach and in your liver. So the little bag of Takis, the little one. Have you guys ever held a bag? They're so dense, they're heavy. So, and if you look at the front, it's like 150 calories. So my moms are like, oh, it's only 150. And I'm like, let's see the back. About 4 servings. About 4 servings. I love about. You know, about 4 servings. About. So that's about 600 calories. I'm like, no Takis. Cero Takis for like nobody. So your families are going to tell you, oh, we eat fruits, we love apples, we eat vegetables, but they add the Takis on the side. And this is what's driving the fatty liver, just this carb load. So you need to be very specific. I tell them, cero Takis, cero, like not even one. Because also they're so nice. They buy the big bag and they share with everybody, you know, and they all have the orange fingers. I'm like, no. Nothing from that aisle in the supermarket. You tell them that specific thing, and that it's easier to comprehend than adding fruits and veggies. They already eat their fruits and veggies. They already eat like the healthy whatever, like no juices, no, we never go to Pizza Hut, and you're like, how many Takis a week? And they're like, every day, all day. I'm telling you, it's a problem. So that's what I usually tell my families. I'm very, very concrete in what I tell them. No Takis, no hot flaming Cheetos, because again, they're like, oh, I don't eat Takis, I eat the hot flaming Cheetos. Same. Nothing that comes in a bag, nothing from that aisle, because usually in that aisle, that's also where they have the sweets. So they understand that. Nothing from that specific aisle, and that's how you're gonna target them a little bit more than something as vague as increase your fruits and your veggies. Does that make sense? Cero Takis. This is like an actual video. There's like, it's like East versus West, like Biggie versus Tupac, like who can eat the more like hot flaming Cheetos and Takis. I'm like, oh my God, this is terrible. So I trained in Texas, and there they ate more Cheetos. So when I moved here, I would ask all my patients like, oh, do you eat Cheetos? And they're like, no, 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 we eat Takis. So again, you need to kind of ask the families what they're doing. And really, at the end of the day, it's about normalizing their carbohydrate intake. I'm Hispanic, I know what I eat, like I said. We eat about 90% of our diet is carbs. When normal, it should be about 50%. 90% of what I eat is carbs. So one of the other things that I tell the family is like in a plate, so 50%, or if you're gonna eat a sandwich. So you have 2 slices of bread, and if you put just like one little like ham and one little cheese, it's gonna be way more bread than protein. And they comprehend that a little bit better than cut down carbs. I'm like, less than half of your meal is carbs. If you put the plate, rice can only be less than 50%. Like if you have the big bowl of rice, that's too much. So those are kind of like little guidelines that you guys can use to cut the carbs and cut the sugar. Sugar, no Gatorade. That's another thing that I'm very specific, because it's hard sometimes for them to also understand the sugar. But really at the end of the day, it's about normalizing the carbs. Another struggle that we have is with our dietitians sometimes, because the culture in Seattle is we don't like to limit anything. We want them to have everything. And I'm like, no, you need to limit the carbs. You need to eliminate the sugar. They're gonna get the sugar somewhere else. But if you're not very specific with them, this is gonna keep progressing, because again, they already eat the sugar, the fruits and the vegetables. So you need to give them limits. You're really gonna benefit them. But every time I say limit, it's like, no, we can't. So, just a little bit about medications. Really, nothing works. So they did studies, and this is just me summarizing it for you. No medication works, unfortunately. We actually are doing a trial right now. I'm enrolling kids to do a trial with medications, and the results have not been very promising. If they don't lose weight, if they don't change their lifestyles, you can give them whatever medication you want. Nothing is gonna work. So metformin, like excellent for kids that have fatty liver and insulin resistance, but doesn't do anything for fatty liver. I'm just gonna skip this for time purposes. Again, vitamin C, fish oil. Actually, some studies show that fish oil increases the amount of NASH, like the inflammation in the fatty liver. So we really don't use it. You use it for other stuff, but we don't use it. So whenever I hear anybody saying medications for fatty liver, I'm like, no, unfortunately, nothing works. What about bariatric surgery? So actually, through endocrinology, they are working with a bariatric surgeon, and they have very strict rules. And the problem with bariatric surgery in kids is that if you don't treat their underlying reason why they're so obese and overweight, bariatric surgery is not gonna be a long-lasting thing, okay? So all of these kids are depressed, all of them. They all get bullied, they all have issues that this is how they cope with food. So if you don't fix that and you don't spend the time to find out what's going on, they're gonna fail their surgery. And most of the criteria that they use is based on insurances, but almost all programs require that the kids have lost some weight before they actually get sent to bariatric surgery. But it's out there. I saw a girl in Yakima last year that she was 12, and the mom came specifically looking for a referral for bariatric surgery. I'm like, hold on. She's like, yeah, they're doing bariatric surgery for kids. And I'm like, you have a 12-year-old girl. What's going on? But it's out there. So really, at the end of the day, what works? You need to get them to lose weight whichever way you can. Now, the patient needs to be motivated, and the family needs to be committed. You cannot just talk to the patient. You need to talk to the mom, the dad, the neighbor, the grandma. I tell them, bring the abuela. I want to see the abuela, because they go, I have a kid that lost 20 pounds in 6 months, and I'm like, yeah, went to the grandma's house for Christmas, gained the 20 pounds back. Come in January, I cried. I'm like, where did all the effort go? And he's like, I'm like, no, I want to see your abuela next time you're in clinic. Or bring me your dad. Because a lot of the times I come with the mom, and the mom is like, well, dad takes them out for ice cream on weekends. And I'm like, is that the problem? Perfect, bring them to me. You need to. I know, I yell at them. I'm like, abuela, no. And they're like, oh, okay, no takis. Like, that's right, no takis. It's better, it sounds better in Spanish. Like, I want to see some tears. That's how I know. They're like, no, we want takis. I'm like, I'm sorry. But this can be done, and I promise you it can be done. And how do I know? This is me when I was a baby, big diaper, I know. I'm like, Ma, send me pictures, I asked my mom, of when I was younger, and look at me eating carbs, sugar. My mom is like, do those pictures work? And I'm like, they're perfect, thank you. This is all I wanted. I'm like, I knew it, I know. And I have 3 brothers, but this is my youngest. Again, eating ice cream. Look at the face of happiness right there, eating chocolate ice cream. Remember, ages 6 to 11, huh, right? He was skinnier. And then suddenly you start seeing a little bit of central adiposity here when he was in kinder. Then a little bit bigger, me, my oldest, I didn't have teeth in that picture, and my youngest, but my youngest was skinny. And then this is us. My 3 brothers were really obese, but especially the youngest one. He was really, 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 really overweight. And he had a baby, and he couldn't run. And he almost had, he started having, chest pain, and and he was, 26, and he's like, I'm too overweight. So he took it upon himself to lose weight, but it was him. My mom was like, he really wasn't that obese. I'm like, what are you talking about, lady? She's like, gordito, just a little bit. I'm like, lady, you're part of the problem. This is why we all had fatty liver. When I was younger, the AAP guidelines were not out, so I don't know if my liver enzymes were high, but I bet sugar and candy and all that. So this is him now. He lost, I know, I'm so proud of him. And and that's my niece, and you can see a little bit of like also central adiposity. And again, I tell my mom, Ma, she's like overweight. And she's like, don't you dare say that she's gordita. I'm like, oh, so it's a problem. So you need to engage with the families. You need to tell them, your child is overweight, your child is obese. Another thing that I hear a lot is that they're worried about then triggering them into like a complex and like eating disorder, and Dr. Evans is gonna talk about that later. I've seen one girl that then started self-restricting, but it was because other people were bullying her. So I know it can happen, but you need to give them the right tools, and they need to understand that food causes the same damage as alcohol. That's why we distinguish it, non-alcoholic versus alcoholic fatty liver disease. And I tell them, this is like they're having 10 tequila shots a day. And they're like, ¿qué? I'm like, yes, Takis, it's like tequila. And it really takes a village because all these kids have so many other things. They all have insulin resistance. They're all depressed. 100% of them are depressed. You guys see it. All of them are depressed. And it really takes a village. And this is kind of like my dream team for fatty liver. And I partner with endocrinology, and now we're seeing insulin resistance and fatty livers together. And we have athletic trainer, dietitians, social workers, psychologists to actually kind of help these kids. You guys don't have the time. In a 20-minute clinic visit, you don't have the time to see these kids and like give them the tools that they need. Send them to us. We'll be super happy to see them. And in the referral, put, I want Dr. Blondet to see my patient. I think they have fatty liver, and I'll see them. So in summary, fatty liver is the most common cause of chronic liver disease in the US and also in Europe. We don't know what triggers them from fatty liver or bland steatosis to hepatitis. You need to get them to lose weight, and they benefit from multidisciplinary approach, and that's what we're able to provide for them in Seattle. Thank you.
Does anybody have questions?
Don't be shy.
Do you recommend the lab work be done fasting?
So lipid profile needs to be fasting. The rest don't. So it's up to you guys. I hardly ever check them fasting unless I'm doing a lipid profile. But I know they're going to have this lipidemia. I actually use the lipid profile more. There's diseases that you have like an odd fat distribution, and then you have like, again, skinny NAFLD. So only if you're wanting to do the lipid profile, but not the ALT and the AST, or the hemoglobin A1C, for example, which are part of your screening as per the AAP. So, yes. So if you code as an elevate, like a BMI above 95, and if you put obesity, it should be covered. It is covered because the AAP recommended that to be part of the screening. So you cannot put well child. Probably you have to put obesity as part of your diagnosis, or overweight and acanthosis or something like that. It recurs. It recurs. So you give them a new liver, and they feel great, and they go back to the Takis, which is why it's important to give them the tools that they need, and why most programs require weight loss. Have you guys ever seen my 600-pound life in TLC? They lie. I know. But perfect example.
First, thank you for having the lecture after lunch.
I know.
I think we should vote her for after lunch lecture.
Hopefully they didn't have Takis for lunch, though.
But my question was, so I saw the screening protocol starting at 10. In your experience, what's the age range, youngest you've been seeing, and how long to progression to transplant?
So I have a couple of 4-year-olds that, again, it's great pediatricians that they're like, oh my God, this child is at the 100th percentile of weight, and then they screen them for ALT and AST, and they send them. I have a couple others that are very overweight, and their liver enzymes are normal. And we start targeting them since a really young age. So I tell you, If you're worried about their weight, check an ALT. Even if it's normal and you're still worried about their weight, you can send them to me. Again, I've seen a couple of kids, Hispanic, super. I have a kid that she's 5 and she cannot even sit up to tie her shoes because she's so overweight. She rolls on the side. So I'm like, Mom. And she's like, nah, she looks good. I'm like, I'm not saying she doesn't look good. I'm just saying that you're hindering her ability to have a normal childhood. So if you're worried about them, I'm worried about them too. Absolutely. You need to convince them that food is a problem and their obesity is too, and you can't. And some people will get offended. That's fine. I have a couple of parents that get offended and they come back. They hear it again. The most important one that needs to hear is the child. That 16-year-old male, that's the one that's easiest to target. You tell them and they start losing weight, they feel good, the girls look at them. Success story after success. Girls, it's a little bit harder because I'm beautiful just the way I am. And I'm like, you're beautiful. I'm not saying that you're not beautiful, you are, but you have fatty liver and this is gonna kill you when you're 30, 35 years old. And I tell the families, they're gonna need a liver transplant and they're gonna die waiting for a liver transplant. And I use those words and they cry and they get upset, but if I don't tell them, who will? So you guys feel empowered as a pediatrician, as a general practitioner. You tell them, show them the growth charts and tell the families why you're worried. Liver disease is something very concrete and they usually understand because they usually have alcoholics in the family that have died from liver disease. You tell them, food is like tequila for the liver, which is true. Takis are like tequila.
We have time for one more quick question.
Absolutely, and not all of them will come. And that's another way. They come to my clinic, and I can tell if they're not prepared to change. And I tell them, come next year. Come when you're prepared. So try to see who you think is going to benefit the most or who the ones that you're worried about the most. I go to Yakima as well. I don't go as often, but the nurses are pretty good at trying to find those fatty livers for me. Not find because they're everywhere, but like put them in my clinic. Just at least tell the family. At least do that. Tell them your liver numbers are high. Because I see a lot of kids that either they weren't told or they didn't get it, but at least make sure and document that you told them. And every time they come to the clinic, bring it up. Remember, you had liver numbers that were high last year. They're abnormal. That high is not good. Like the 100% weight, 100, you don't want that 100, So make sure that you tell them because really, these are the kids that are going to be adults and are going to be cirrhotic and they're not going to get transplanted. So.
Thank you.
Thank you, guys.